السلام عليكم ورحمة الله تعالى وبركاته ومساء الخير عليكم وين ما تكونوا. We are happy to welcome you to this lecture in the series of breast um, um, ultrasound lectures. Um, Today's lecture is about the implications of understanding sonographic anatomy in interpretation of the breast ultrasound. This is the fifth lecture presented by Dr. Rabab Mohammed, a consultant radiologist. Please join me in welcoming her. Thank you, Dr. Rabab, for your effort and for this amazing lecture. You can start now.
Thank you, Nauras. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين حبيبنا ونبينا محمد بن عبد الله وعلى آله وصحبه وسلم. Greeting all and welcome everyone to our continued discussion on understanding sonographic anatomy and its implication in the interpretation of breast ultrasound, the fifth lecture. Why it is stuck? Okay. Let us go through some reviews that have already been discussed before and can help us to understand topics of today. As we know, the breast is a complex organ composed of epithelial elements, the lobules and ducts, connective tissue, stroma, and adipose connective tissue and adipose tissue, both forming the fibrofatty stroma or supportive stroma. As we said, that ultrasound is widely used to evaluate breast parenchyma and can distinguish much more detailed structures than those found on mammography. Each component has different ultrasound characteristics and echogenicity that make it easier to identify. And to make it easy, we compare it with histopathology images. If we look for this ultrasound image, here we can see what?
Sorry, we cannot see the presentation.
Is not shared?
No.
Okay.
Yes,
Is
now
it
we
shared?
can.
Now it is shared?
Yes.
Okay, okay. Sorry, let us go. Now you can see it?
Yes, we can.
Okay. So, talking about this image, what is this structure? Is a breast lobule, not a fat lobule. What is the difference between breast lobule and fat lobule? We discussed it previously. The fat lobule is part of the fat stroma. The fat lobule is part of fat stroma, while the breast lobule is part of the gland, part of terminal duct lobular unit. We said the lobule and extralobular, these are lobule, and these are extralobular terminal duct. Both represent the terminal duct lobular unit. Okay, and here we can see a duct, a normal duct, collapsed duct. And as we mentioned previously, we said the intralobular stroma, this is the lobule, and the intralobular stroma is what? Is it compact or loose? The intralobular is a loose connective tissue stroma that appear as gray, while the interlobular stroma is a compact one. This is the red one, interlobular stroma is a compact one that represents the whitish area on ultrasound, while the periductal stroma and intralobular stroma are loose connective tissue, appear as gray or isoechoic to the fat. And we mentioned previously also we said that it has a bilayer cells, okay? The inner or the luminal epithelial cells and the outer or basal myoepithelial cells resting in the basement membrane. And the relevant clinical relevance of this is that cancer arising within and not breaching the membrane, we call it in situ carcinoma. When breaching this membrane, then it will become invasive cancer. Okay. Also, the last lecture, we started discussing breast composition, and we said that based on the balance of the amount and distribution of the stromal, adipose, and glandular tissue, there are 3 types of ACR breast composition pattern: the homogeneous the homogeneous background ecotexture fat, the homogeneous background ecotexture fibroglandular, and heterogeneous background ecotexture, and they try to harmonize the breast composition on ultrasound with mammographic density. Okay, what is the breast composition in this ultrasound image? Quickly, please.
Homogeneous background, ecotexture, fibroglandular.
Excellent. And this? Oh, let us take some examples,
Homogeneous
for revision.
background. Homogeneous background, ecotexture, fibroglandular.
Homogeneous?
Homogeneous background, ecotexture, fibroglandular.
Is not a heterogeneous. We have patchy area of hypo intermixed with this hyper. Make it a little bit heterogeneous. What about this one?
Homogeneous background, ecotexture, fatty.
Excellent, fatty. What is this? What is this structure?
This is a pectoral muscle, pectoralis.
Excellent. Why it looks like that?
It is striated appearance.
Because there is fat involutions, you see. The fat involutions make it like that. And this?
Homogeneous background, ecotexture, fatty.
Fatty, excellent. Here?
Heterogeneous background, ecotexture.
No, this is not heterogeneous to here. Why it is not heterogeneous?
Because the terminal duct lobular unit, it is a moderate terminal duct lobular unit.
Because it is uniform. Uniform, the isoechoic structures are more or less uniformly distributed of uniform shape and size. That is why it is a homogeneous background ecotexture. And here?
Heterogeneous background ecotexture.
Why it is heterogeneous?
There is fat and fibroglandular tissue.
But I can see the layer of fibroglandular. This is the layer of fibroglandular, more or less, is homogeneous and separate from the subcutaneous. I'm talking about the fibroglandular layer. It is not intermixed with hypoechogenicity. It is more or less more homogeneous. more whites. You see, this is homogeneous. It is
Homogeneous
distinct from the fat, the subcutaneous fat. And this one?
This is homogeneous background, epitexture, fat.
Fat, excellent. And what about these bands?
This is a stromal band, or it could be.
Yes, these are the supportive stromal bands. Excellent. And what is the composition of this?
Heterogeneous background, epitexture, fat. Heterogeneous background, epitexture.
Why it is heterogeneous?
This hypoechoic region represents interposed fat, fat.
No.
So this is the gland. So it is homogeneous background, epitexture, fibroglandular.
Yes, this is homogeneous. If you look here, the whole area is hypo and the remaining is hyper, not intermixed together. Yeah, this is homogeneous background. And what do you expect to see this pattern of the parenchyma at what age group?
This could be in the lactation.
Why?
In pregnancy.
Why? Look at
Puberty.
this. Yes, excellent. Excellent. This is seen at puberty. What about this one?
Homogeneous background, epitexture, fibroglandular.
Same. Yes, this is the same. This is what tenors is this?
Tenor 2.
Is it 2? Oh, this is very large disc, very large bud. It extends so far beyond the areola.
3.
This is 4. What is this? The parenchyma here.
Heterogeneous background, epitexture.
What is tenor stage? Is this?
This is tenor 2. 3.
This is 2. So it is homogeneous. That is homogeneous, okay? So it is a homogeneous background. So today we are going to discuss ultrasound findings of physiological changes and normal types of ultrasound morphology in different ages. As we have mentioned earlier, the breast development is a complex process with various phases. And like other organs, it starts intrauterine as a dermal thickening, forming the primary mammary ridge, which involute and remain only over the chest, influenced by placental hormone to form the primitive mammary gland. Do you remember that? I've discussed it earlier. Okay. This represents the prenatal phase of the development. Okay. Then the development continues during pubertal and menstrual cycles, pregnancy, and finally at menopause. Here we can see these illustrations. This illustration represents the terminal duct lobular unit, and this is a terminal duct. And here we can see these are the primitive ducts, okay? And then the primary complex, the rudimentary terminal duct branchings in a pubertal stage in a 15-year-old lady. Extralobular extralobular duct branching with the rudimentary terminal duct branching and the terminal duct buds here. Okay, these illustrations of the terminal duct lobular unit in a nulliparous state. And here, this is the 2-year-old nulliparous human mammary gland having well-developed lobules and acini. You see, this is the adult form mammary gland. And here you can see these clusters, large amount of lobules in a pregnant lady. And when you look here, you can see this dilated ductal system with atrophic lobules in a 55-year-old menopausal woman. When reaching 80-year-old, also the ducts along with the lobule get atrophic in a post-menopausal state. Okay. As you know, the breast is primarily influenced by the endocrine system, and except for the first prenatal phase, the primary ridge, from the second prenatal ridge, and all of the following breast development and involutions are hormone dependency. Okay. Let us first go through the journey of breast development after birth. We would like to understand the various normal and abnormal breast ultrasound looks from birth to puberty. Starting at birth. As we mentioned earlier, the baby born, boy or girl, will have rudimentary gland. So from birth till puberty, this we call it the pre-pubertal phase. And as we mentioned earlier, there is no difference between gender. Both boy and girl in pre-pubertal phase have the same development, or the rudimentary gland, rudimentary ducts. So they will have tenor stage 1. What is tenor stage 1? Tenor stage 1, do you remember this? We said this is the primary. Do you remember it here? The primitive, I mean, sorry, not the primary, the primitive mammary gland. Do you remember? We said this is the first stage. This is not influenced by hormone, the ectodermal thickening. Then this influenced by hormone, the primitive mammary gland. And the baby born with this primitive mammary gland and stay like that until puberty. So what do we expect to see in the pre-pubertal state, both in male and female? We'll see tenor stage 1. What is tenor stage 1? The same as the baby born with the primitive mammary gland. Okay, so what we can see only here, the elevated papilla or the nipple, and this is the primitive mammary gland, appear on ultrasound as just ill-defined, small ill-defined hyperechoic retroareolar tissue. There is no additional development of stroma or parenchyma beyond has occurred in infancy. The same. You see? Another example of ternary stage 1 at 8-year-old. You see here the stroma a little bit more, but still ill-defined hyperechogenic area. You see? The primitive primary gland. Again, ill-defined hyperechogenic area. Tenor stage 1 in a 7-year-old healthy girl. Okay, this is the fat here, and this is the ill-defined hyperechogenic subareolar bud. It's form of just a primitive. Do you remember these ducts? 15, we said 15 to 20 ducts, rods that cannulate under the influence of hormone, forming the ductal system embedded into the mesenchyme, which forming the stroma. So these primitive ducts and stroma forming this ill-defined hyperechoic area in ternary stage 1. But clinically, there will be no palpable bud tissue, no palpable bud, no palpable breast tissue, only elevated nipple, slightly elevated papilla or nipple. Okay. This is the what we discussed is or was the pre-pubertal stage. Until the puberty, both female and male were the same or are the same. Okay? At the puberty and under influence of the hormonal, female hormone, okay, then another stage of development occur over 2 to 3 years. What will happen? This is the primitive mammary gland, the primitive lactiferous ducts, 15 to 25 or to 20 to 25, okay? The primitive representing tenor stage 1. Only the main ducts are found at birth and the pre-pubertal phase in both girl and boys. Then at puberty and under influence of estrogen and growth hormone, complex branching or morphogenesis start to occur. Can you see it here? This is the complex branching. Here the main ducts, and here start to develop more complexity in the ductal system and start to develop a terminal end bud, develop bud that later forming the terminal duct lobular unit. And here this represent tenor stage 2, and between this and this, you see, we have in between tenor stage 3, 4 until 5, where the full form of ductal branching system and terminal ductules form at the terminal end of bud. These terminal end bud forming cluster of terminal ductules and well-formed lobule. You see? So the duct system comprises a modest network of ducts and branch into connective tissue and end with a terminal bud in the early stage of puberty. At the late stage of puberty and full mature adult breast, they call it virgin adult stage. The ductal system now comprises a fairly advanced network branching ducts that have growth in length and end in a cluster of terminal ductules forming fully the terminal duct lobular unit. And the growth of ducts and periductal stroma is estrogen dependent. And if you look here, the bulk of lobules in mature breast are embedded in a fibrous stroma. You see, this is the red, okay, or these pink lines around the lobule are the connective tissue or the compact interlobular stroma, and within the acini here, you see, embedded in intralobular loose connective tissue stroma. So, hypothalamus gonadotrophin releasing hormone stimulate pituitary gonadotrophin hormone that stimulate ovarian estrogen and progesterone, which strongly influence on lobular ductal proliferation and the development and the rapid growth of breast at the onset of puberty represent TLARC, which under the influence of multiple endocrine and genetic controls, usually or typically occur between 10 and 12 years of age. However, we can observe it as early as 8 or as late as 13. What does it mean? It's supposed to be considered abnormal if below the age of 8 or above the age of 13. So this is Tanner stage 2. What is Tanner stage 2 or Tanner 2? What is Tanner 2? We described it earlier a little bit. We said early, it represents the TLARC, and it is early in puberty. Okay? Start the primitive primary duct, start to get or to form complex branching ductal system. This complex branching ductal system represent Tanner 2. So now we start to see hypoechoic core within the ill-defined hyperechogenicity, but it's supposed to be just underneath to the areola. Look here, what we will see just behind the areola. And clinically, we have elevated nipple or babilla and slightly prominent breast tissue. You can palpate a small lump, but it is confined to the nipple areolar complex, and there is no evidence of areolar elevation. Okay, so you will see on ultrasound just hypoechoic nodule, okay, or area at the core or at the center of the ill-defined hyperechoic, both not exceeding 2 centimeters. Another examples of Tanner stage 2, look for the age at this. If you look here, this is a 7-year-old having Tanner stage 2. Now, this is a 9, 10, 7 having Tanner stage 2. There are variations in the age group. Okay, this is a gray scale. This is in this age is early TLARC, because expected to be started at the age of 8. But at the end, this is Tanner stage 2, confined to the nipple areolar complex, the area of hyperechogenicity, and the central or the core of hypoechogenic nodule or whatever. And this represents what? These are the complex branching duct embedded into the stroma. Okay. Here, a little bit different. It is not a nodule. It looks like somewhat linear or branching hypoechogenicity, but still are not extend beyond the nipple areolar complex. So this is still Tanner stage 2. Clinically, as we mentioned, there is a palpable lump, but it is confined, it is small and just confined to the areola with slightly elevated nipple. And this, as we mentioned, represent the first pubertal sign in female, which called TLARC. Again, this is 9-year-old girl. What we have seen here, a little bit larger hyperechogenicity. The disc or the butt a little bit larger. Can you look for the one here? Though it is branching, but confined to the nipple areolar complex. And as we mentioned in Tanner stage 2, this is about 2 centimeters. Here, this is more than 2 centimeters, approaching a 3 centimeters, and extend slightly beyond. Even if you look for the illustrations in this, if you compare it to this one, can you see it here? Just behind the nipple areolar complex. And now, can you see here, it extends slightly beyond the nipple areolar complex, but it is roughly about 3 centimeters. And the hypoechogenicity, it appears like star-like or satellite-like hypoechogenicity. Within even the hyperechoic, it looks like a little bit larger. But there is no here the elevation of the papilla and slightly more prominent, palpable, but there is no elevation of the areola. The breast and the areola forming smooth, same contour. This is stage 3. Can you see? Branching hypoechogenicity, star-like or satellite-like. Look for the variations between the three of which are stage 3. Okay, but there are variations. At the end, this is about 3 centimeters or slightly less. Okay, more than 2, and a little bit the hyper and hypoechogenicity are larger or more prominent than the Tanner stage 2. And can you see? Here we can see the enlargement of the breast. Okay, the breast is enlarged, but the areola, as we mentioned, the areola is not separable from the breast. It has no mount at stage 3. And this is 13-year-old. She has Tanner stage 3. And if you can see here, this is the branching expanded hypoechogenicity within a hyperechoic hyperglandular tissue. Okay, this is 8-year-old having Tanner stage 4. Can you see? If you compare, this is Tanner stage 3. There is no elevation of the areola. There is only elevation of the whole breast as smooth. But if you look here, we have elevation of the breast and we have another mount, elevation of the areola. Here we can see a second mount. Okay, a second, the areola elevated, forming a second mount. If you remember, okay, I'll discuss it later. But here, both the hyperechogenicity and hypoechogenicity are larger than the previous, extending for 5 centimeter or a little bit more. Again, stage 4 in a 14-year-old healthy girl, the disc, when you look, it simulates or it is similar to stage 3. However, it is a little bit larger. Stage 3, about 3 centimeter disc, while stage 4 approaching 5 centimeters. And as we mentioned earlier, here, the areola forming a second mount at stage 4. Okay. This is again example, 2 examples of stage 4 with magnification here. A larger disc, you see, is still extending from the nipple areolar complex, centrally located and extending peripherally for about 5 centimeter or a bit more, with central hypoechogenicity and peripheral hyperechogenicity. Compare it with this one. What do you think? Is it the same? No. This is a little bit more diffuse, though this is simulate the central hypoechogenicity and peripheral hyperechogenicity, but now you can see even, you see, oval hypoechogenicity within this hyperechogenicity, and in this one, these are oval hypoechogenicity diffusely scattered throughout a hyperechogenicity, and this represent a mature or 10 or 5 stage mature breast tissue. Are you following me? And now you can see the subcutaneous fat increasing subcutaneous fat and appear not like in the previous. Here you cannot see a subcutaneous fat, but here you can see even the layer of the subcutaneous fat, it well formed. Are you following me?
Yes, yes.
Okay. Again, this is thinner stage 5. It is more or less similar to the adult breast. Can you see it here? This is 15-year-old girl. Can you look for the breast? This is the more or less the same as adult breast. Hyperechoic with scattered oval isoechoic structure and well formed the subcutaneous fat, though it is relatively thin due to large, thick mammary zone. And now, if we look for the breast clinically, there is no secondary mount of the areola. The elevation of the areola in ternary stage 4 now recessed back, you see, and make a smooth contour with the remain of the breast. Do you remember this? If it fell, if the this secondary mount of the areola failed to get back or recess back to its original place and form one contour, what will happen? Do you remember? Okay. Again, this is just heterogeneous echogenicity of the parenchyma, and here subcutaneous fat in tenor stage 5. Another examples of tenor stage 5 with homogeneous and heterogeneous fibroglandular parenchyma of mature adult breast. Okay, and no longer central hypoechoic and peripheral hyperechogenicities that seen in tenor 2, 3, and 4. Here you can see there is no secondary mount of the areola, and the breast elevated, okay, demonstrate B5 or a mature adult breast configurations and with a single breast contour and become rounded. This is tenor stage development as we have seen. You see, stage 4 here, you have secondary mount, and you can compare it here. This is stage 1, no parenchyma is seen, no breast tissue. Here we can see very small breast tissue behind the nipple, expanding, more expansion, but central, and here become diffuse in tenor stage 5. And here, if you compare ultrasound with the clinical in tenor stage morphology, there is no hypoechogenicity here, no breast tissue, no clinical palpable breast tissue. Small elevation of the papilla and a small palpable breast bud. Ultrasound demonstrate very small hypoechoic core within the peripheral, small hyperechogenicity just behind the nipple without elevation of the areola, expanded in stage 3 and become star-like or branch-like and almost reaching about 3 centimeters with more palpable bud, prominent breast tissue, and more palpable breast bud, but still smooth contour, no elevation of the areola. Stage 4, more expansion, reaching 5 centimeters or a bit more, and with elevation of the areola forming secondary mount. So there are 2 elevations in stage 4, elevation of the areola as well as we have 2 contours, elevation of the areola as well as the prominent breast tissue. And the areola recesses back in stage 5, okay? And forming smooth contour, rounded shape of full mature breast tissue and lacking the central. It's supposed not to be like that. It will be diffused throughout the breast. There is no central hypoechogenicity and peripheral hyperechogenicity. It will be seen, this iso or hypoechogenicity, it will scatter throughout the breast. And you know, what does it represent? As we mentioned earlier, the primitive ductal system in prepubertal child contains just a rudimentary ductal system and stroma that represent tenor stage 1, the ill-defined hyperechogenicity. With the onset of estrogen secretion by ovaries, then glandular tissue enlarge quickly, forming thelarch, okay, which occur before menarche. So what is thelarch? Thelarch is rapid, continuous growth of the breast at the onset of puberty. Essentially, look for the steady, rapid, steady, continuous growth. of the breast at the onset of puberty, essentially under the influence of multiple genetic and endocrine controls, as we mentioned earlier. It's characterized by appearance of breast bud, usually corresponding to tender stage 2. Okay, then it get maturation occurs by more alveogenesis development and get mature. So CELAR, as we mentioned, CELAR correspond to tender stage 2, which is usually the first clinical recognizable stage of puberty. So it is the first secondary sexual characteristic to develop, preceding pubic hair development by about 6 months. And as we mentioned, it's typically between the age of 10 and 12, ranging between 8 and 13. So if the girl does not develop breast at the age of 14 or more, then prompt further investigation and endocrine consultation is warranted. Okay, so what is transient SLAC? Do you know what is transient SLAC? Is the premature SLAC in which breast development start earlier than normal guidelines and then regress. Okay. These are examples of the 5 stages of tenor. Can you tell me, number 1 represent which stage? Or if you want to select each, yani number 2, number 3, or 5, or whatever, but tell me which one corresponding to what stage of tenor, or to which stage of tenor.
1, tenor 2.
This is tenor 2?
Yes.
Okay, and this?
Tenor 2 also.
This tenor 2 and this tenor 2, so here, look for this one. I don't accept.
Yes, 3.
Okay, so here, type. Okay, let us start by easier. This is tenor number 4, tenor
1.
How come, Suhair? You are confused today. This tenor 1, this is the pectoralis muscle, and this, what is
5.
this layer? Huh?
Sorry, this is 5, sorry.
5, this is mature breast. These are,
5.
yeah, these are the gland, isochoic glands or lobules within echogenic or hyperechoic stroma. But here I can see small, okay, hyperechogenicity with central nodule of hypoechogenicity representing tenor.
Retroareolary. This is retroareolar.
Yes, this is tenor.
Tenor 2.
Typical tenor 2. And this one?
This tenor 1.
This tenor 1, excellent. 5 tenor 1, 3 tenor 2. Type. Here I can see retroareolar branching and smaller amount of surrounding hyperechogenicity representing tenor
4.
What is the difference between this and this?
This when not branching.
Between 1 and 2, huh?
Development of the retroareolar hypoechoic area in 1 is less than in 2. So
but look for the whole, not only the whole area.
The hypoechoic area is progressing into in 1 and 2. The hyperechoic area, I think, same in 1 and 2. The difference in the hypoechoic area in 1 less than 2.
But usually we are talking about the whole disc. Which one is larger? Larger in 1 or larger in 2?
Larger in 1.
There are, yes, but there are variation. That is why I brought for you multiple examples to show you there are a lot of variations. But at the end, I told you there is one principle. The whole disc, the central hyper, the difference between 5, 2, the difference between 1, 2, and the remain, there is no central hypoechoic core within the hyperechoic parenchyma or the rudimentary tissue. This is hyperechogenicity. Rudimentary tissue behind the nipple is small, ill-defined, and that is it. No significant hypoechogenicity associated. Okay, this is 1. 5, it is mature breast. It is diffuse. There is no central hypoechogenicity and peripheral hyperechogenicity. The hypoechogenicity is scattered within, evenly scattered within the hyperechogenicity, separated 5 from 2, 3, and 4. 2 is a small disc, just confined to the nipple areolar complex. You see, it is not more than 2 centimeters. That's differentiates tenor 2 from 3 and 4. And then the more simulating each other are 3 and 4. Okay, both of which having central, okay, spider-like or branching hypoechogenicity extending, okay, peripherally within hyperechogenicity. The difference between 4 and 3 is the whole disc, including both echogenicity, hypo and hyper. 4 is larger than 3. 3 approaching 3 centimeters, while 4 is more than that, approaching or reaching 5 centimeters or a bit more. You got it?
Exactly.
Okay, so this is how to differentiate between these. And this is important for us as a radiologist. Okay, what is tenor in this stage, in this image?
Tenor 1.
I think it is 5.
Who said 5?
Sarah.
Yes, excellent. This is 5. Today, Suhair is confused. This is 5. Really, this is 5. This is parenchyma. Can you see it? You can see the isochoic oval structures surrounded by hyperechogenicity, the stroma, and the lobule. This is a typical of mature breast. This is tenor stage 5. Okay, let us go for the histopath image. This is 11-year-old girl showing what? We said this pink area represents what?
Fibrous tissue, fibrous stroma.
Fibrous, excellent. This is the stroma. This is a compact fibrous interlobular stroma. And here we can see a developing lobule. So we can, what we have seen in an 11-year-old girl, abundant of stroma. Abundant of stroma. You see, as we mentioned, again here, this is the pink area is the
Fibrous
interlobular compact stroma. And these are lobules, okay? And this is inside here, this purple is intralobular stroma. These are acini and intralobular stroma and intralobular ducts. So, as we mentioned earlier, growth of ducts and periductal stroma is estrogen dependent, which is the more prominent at the early pubertal stage. So, early pubertal stage, the female breast is usually appear as hypo, iso, or heterogeneous. Which one? What do you expect to see? Stromal proliferation is a feature most consistent associated with changes in mammographic density. The more stromal, the more dense is mammography. Do you agree?
Yes, yes.
That is why in young ladies, mammography is extremely dense. What about the ultrasound texture? What about the stroma? The more compact stroma on ultrasound, it appears as
hypo.
It appears as
Hypoechoic the compact.
appear as hyperechoic the stroma.
We said
But the
the
compact.
we said the lobule, intralobular loose appear as gray.
Okay.
That is why as isoechoic to the fat. But the interlobular is compact and is extremely white. That one represent the whitish appearance of the fibroglandular component. Okay? That is why usually it looks like that. It looks like more hyperechoic with small lobule scattered within the hyperechogenicity. This is in young pubertal ladies or girls. Huh? Which tenor stage is this? 6-year-old girl.
It is one.
It's one. Excellent. This is one. Only hyperechogenicity. This is tenor stage 1. Ill-defined subariolar hyperechoic nodule. Tenor 1. And this one. 14-year-old girl.
This is almost, I think,
3.
Huh?
4.
3 to 4. لكن 3.
3 to 4.
Excellent. 3 to 4 accepted. It looks large, but if you look, it looks more than 3 centimeters. Expanded. Look for this area. Expanded throughout all this and even approaching the pectoralis muscle. So this is 4. Unexpected. This is 13-year-old, 14-year-old. This is tenor stage 4. Okay, more or less a little bit diffuse, but still we maintain it. It maintain the central hypoechogenicity. So this is tenor stage 4. And which tenor stage is this one?
3.
Huh?
3.
3.
3.
3. Is it normal or abnormal? Can we consider this as a normal? I accept it simulates the tenor 3, but is it a tenor 3? And why? Huh?
Usually it will be symmetrical both sides of the nipple, but now at the right side, it's more hypoechoic. I don't know.
Can you read the clinical history first?
Yes, abnormal. Boy.
Why?
Gynecomastia. In a boy, yes.
gynecomastia. This is physiological gynecomastia.
Tricky,
So
tricky
we
question.
should always consider the clinical. We should always consider the clinical. Since the introductory lectures, we are repeating, correlate all breast imaging, but we have to go back and correlate with the clinical. We have to consider the clinical. Always we have to consider the clinical. So what is physiological gynecomastia? As we mentioned earlier, we said the breast, the rudimentary mammary gland is equal at birth and pre-pubertal phase, both in boys and girls until puberty. At puberty, what will happen or what happens in girl? The estrogens and growth hormone accelerate more ductogenesis or the formation of complex ducts, okay? And then the terminal duct or lobular buds that later form the terminal duct lobular units in adult mature breast. This is in female. What about the males? What happens at puberty regarding the boys? However, in the boys at puberty, there is involution of male breast and atrophy of the ductal branching system. Why? Due to significant increase in testosterone levels. And this can explain why the ductal malignancies are rare in the male, okay? And when occur, are located just behind the nipple, retroareolar regions, okay? And that is why there is no indications for screening in male because of this rarity. But why gynecomastia develop? Especially the physiological gynecomastia at the pubertal stage. And what is the gynecomastia? It is the same like tenors. You see, it is a ductal and stromal proliferation due to a temporary increase in estrogen. Some of the boys at pubertal stage, they have a temporal imbalance, hormonal imbalance, with a little bit elevations in the estrogen that result in proliferation of ducts and stroma, like the female breast, exactly the same, forming this tenor-like stage, okay? Morphogenesis, forming this, the morphogenesis. As we mentioned earlier, they have the rudimentary, just these primary ducts, both male and female. This will be atrophic due to the testosterone levels in boys at puberty. But if they have some imbalance, okay, or even later in life, due to any cause, any etiology of gynecomastia, whatever the cause, okay, at the end, the pathogenesis is a hormonal imbalance and elevation of estrogen levels. It will again result in proliferation of ductal and stromal tissue and causing a gynecomastia. But at the end, whatever at pubertal or at any age, as you know, the gynecomastia either occur at the pubertal or at later, at elderly, above 50. But whatever the age, at the end, it has to be central. This is what differentiates gynecomastia from the mass, breast mass or breast cancer. Gynecomastia never be eccentric, because if you look here, the ductal system are central, extending beyond the nipple areolar complex here. This is the primitive. When get branches, so it will branch behind the nipple. Sometimes can slightly extend, okay, to the upper outer quadrant. But at the end, it has to be central and then can be extended to one side. Okay, this is a 20-year-old male presented with bilateral breast enlargement. So, what is your impression? What is the texture of this breast? Today we are talking about the breast ultrasound appearance and the texture of the parenchyma to reach the normal and abnormal regarding the patient age and sex. So this is a 20-year-old male and he has bilateral breast enlargement. Huh? What is the texture? Tenor type?
Tenor 2.
Where is the hypoechogenicity? This is shadow of the nipple.
Shadow.
This is the shadow of the nipple. Caustic
So
shadowing from the nipple, huh? So the texture, this is the texture, the same throughout. But if you look here, it's obviously the breast enlarged, yeah?
Yes, enlarged breast and elevated nipple.
Yeah,
And
enlarged. The breast is enlarged, but why it is enlarging? Why it enlarged?
the fatty parenchyma is
Excellent. The parenchyma is fatty. I ask you, what is the texture of this breast? It is fatty. If it is the female, what is the background parenchymal texture?
homogeneous background, ecotexture fat.
This is homogeneous background texture fat. Excellent. But
Female.
since he's a male, then the diagnosis it will be. It is common in the practice. This is very common in the practice. Even more common than the previous case.
Could be obesity.
Okay, obesity. What we call this type? The role of radiologist to differentiate the patient presented with breast enlargement, sent to radiology department seeking ultrasound examination to differentiate. Since it is bilateral, they will expect gynecomastia. But is there any gynecomastia in this case?
No.
No true gynecomastia. So this is called pseudogynecomastia. This is the pseudogynecomastia. It is really common. You see? Okay, this is a 12-year-old girl presented with rapidly progressive breast enlargement. Sent to me by colleague, one of a Sudanese colleague for opinion. She's working in Saudi Arabia. Thank you for her for sharing sharing with us this case. Since long time, she sent to me. or she has sent this case to me for opinion. Huh? What is your impression about this case?
I think this is almost mature breast parenchyma, Tanner stage 5,
Tanner is excellent. This is Tanner stage 5. Yes.
with no true masses, no masses.
Huh?
No need. يعني, there is no masses, no other abnormality, but it's just yes, Tanner stage 5. For her age, I think this is the premature. Yeah, this is what it's called.
Not only Tanner is, yes, it is Tanner stage 5, but there are something more. Can you see this area? It looks like a mass, okay? And this also look like a little bit difference. And even the texture of the breast, it looks, can you see it here? This is the same patient. Look for this. As if it is lobulated, the parenchyma, it looks lobulated.
Yes.
And almost filling the whole breast with complete paucity or complete lack, not only paucity, lack of subcutaneous and retro mammary fat. There is no fatty layer. The parenchyma filling the whole breast, and it is lobulated. And not only that, can you see this, the ductal system, a little bit what?
Dilated.
Prominent, yes. Is it normal? Do you expect to see like this? And the history, 12-year presenting with rapidly progressive breast enlargement.
For me, she needs a further workup, hormonal workup.
What do you expect? What is your impression? What is your differential diagnosis?
The overproduction of estrogen and progesterone.
Yes. Maybe some pituitary abnormality.
She has no, her hormones were normal.
Hormones normal.
Could be tumoral adenosis.
Is not, it is diffuse and bilateral. Both breasts diffusely seen like this. The whole breast like that. We have discussed this issue before, or this entity exactly discussed. We have discussed it in previous lectures. I expect to remember. If this case seen in lactation or pregnancy, it will be expected, yeah, to see something like that in pregnancy or lactation. But in a young girl, 11, 12-year-old, and ended with huge breast, large breast, excessive overgrowth. What do you call that? Huh?
Macromastia.
Yes, yes. Macromastia. When macromastia seen at peripubertal or pubertal stage, we call it
premature.
No. We call it what? If the breast is enlarging too much, we call anything expanding, enlarging, we call that as the terminology. Just the tissue malu. What about the tissue? If the tissue getting hypertrophied, yeah, or hypertrophy. So what do you think? This is virginal breast hypertrophy or adolescent or juvenile breast hypertrophy. Juvenile, adolescent, peripubertal, or virginal. Okay, breast hypertrophy. And if we connect adolescent, because she's adolescent, peripubertal, juvenile, okay, because she's still young. We discussed that issue. Do you remember it? We said it is a rare peripubertal or pubertal or peripubertal, atypical, excessive, or extremely rapid growth of the breast, rapidly enlarging, commonly affect both breasts, but can be unilateral. The breast can reach several kilometers, and the pathogenesis unknown, suggested that the condition might be a response to end organ hypersensitivity to normal levels of gonadal hormones, or secondary to increased hormonal activity. But this patient has no increased hormonal activity. The histological appearance is just ductal and stromal hyperplasia. There is no lobules, okay? Conspicuous. It is ductal stromal hyperplasia. Do you remember this image? We have seen it before. So here, are you with me? Do you remember the image?
I remember it.
Did you see it before, or have you seen it before?
No.
No? Okay,
No,
so go and review.
No, in the lectures, yes, I remember it in the lecture.
Yes, what I said, virginal breast hypertrophy, macromastia, gignotomastia, adolescent juvenile breast hypertrophy, all these names, we have discussed it. Okay?
But in my practice, I'm not seeing it in practice.
And we said, yeah, we said that usually treated by reduction, surgery, mammoplasty, we said. But we said first, the role of radiology is to exclude the other differential diagnosis. Yeah? We said differential diagnosis can be fibroadenoma, we call it what? Giant fibroadenoma, or phylloides tumor, fibrocystic, BASH, pseudoangioma stromal hyperplasia, or even malignancy. And in this case, this is a case of breast angiosarcoma. So we should not rush and say directly this is juvenile. Clinically, we cannot differentiate here in this case. But being unilateral, it will be more suspicious. Okay? And on clinical basis, also the differential can include breast hypertrophy secondary to endocrine disorders or exposure to exogenous hormones. Okay? Okay. This is an 8-year-old girl with prominent breast. What is the texture of the breast here? The texture of the breast.
Modulus background fat.
Excellent fat. So she's 8. She has enlarged breast due to fat, same as the pseudogynecomastia. Okay, this is lipomatous pattern of enlargement. There is no breast bud here. This is just can be seen in those overweight and obese girls. And in this case here, she's 15-year-old adolescent who presented with right retroareolar lesions. So If ignore this part, but if look for this, what is the, if I ask you in this area, the parenchyma here, is it homogeneous or heterogeneous, or the background parenchyma, or fat or glandular? Surrounding, what is this? What is this structure?
This is simple cyst.
Simple cyst. I'm asking about the surrounding parenchyma of this. So the palpable abnormality is this simple cyst. But what about the surrounding parenchyma? What do you think about the surrounding parenchyma?
I think
Fat.
it is homogeneous fibroglandular.
Fibroglandular, yes, this is the fibroglandular. This is gland. As we mentioned, the gland is isoechoic to the, okay, to the fat. This is a 7-year-old girl with right breast swelling. Mhm.
The right is almost, it's thinner, I think, stage 3 almost.
Excellent, tenor 3. And left?
It's almost 2.
Excellent, this is tenor 2, tenor 3. And she's 7-year-old. So this is?
Premature cell.
This is asymmetric early cell. 7, it is more or less close to it. From my experience, at this age, I was not, or I used not to call it premature, because premature most of the time is regressing. You see, start to be progressed, then regress. But early cell arc at this age usually progress to cell arc. Okay, and especially if the girl has no any secondary signs or any feature suggesting precocious puberty, or she was totally healthy. So just I will call it just an early cell arc rather than premature cell arc. This 9-year-old girl with palpable left breast lump. Huh?
Right tenor stage 1. Left tenor stage 2.
Excellent. Who said right one, left 2?
Me, Suhair.
Excellent. Though this appear larger than this, but this is 2 because there is central hypoechoic. And this is, there is no hypoechogenicity. This is 1. So right 1 and left 2, and she presented with palpable left. This is tenor stage 2. So here we call it, she's a 9-year-old.
Also asymmetry.
Yeah, yes, expected to have asymmetry. Even the normal cell arc usually is asymmetric. But this is, we call it, she's an, is it premature? She's a 9-year-old.
No,
It's
no.
normal.
This is normal. For her age, it's normal to have this. Still, she's within the age of breast development. Okay. This 6-year-old girl with unilateral left breast lump. Huh?
It is almost tenor grade, almost 3.
Yes, excellent.
In the left breast. In the right breast, it's 2. Okay, but for her age, it is very early, premature.
Premature, yes. Excellent. Excellent. This is premature or transient cell arc. Okay, expected. What is the clinical significance here?
It will regress after that.
She's the girl presented with unilateral palpable abnormality. Unilateral. Unilateral.
Yes.
If consider, look, I have seen cases, consider this butt
As a mass.
as a
Okay.
mass and excise and result in a mastic girl. No breast developed. Okay, so we have to be cautious. Okay, we completed the thylarch and premature thylarch. At birth, as we mentioned, boy and girls have the same rudimentary breast, but sometimes both they might have prominent breast tissue. Why? This is due to transient activation of hypothalamic pituitary gonadal axis, and this is usually between 6 and 18 months, okay? But it starts to regress after 2 years. If it persists or progressing by the age of 3 to 5, we have to consider it as pathological, and we have to exclude like precocious puberty, and it warrant endocrinologist and endocrine evaluations, okay? And this is usually a little bit more in girls rather than boys. This is 16-month-old female presented with painless swelling of the breast, both breasts. What do you think here? 16 months. So this is very large. This is almost 4. And in a 16 months, huh?
Premature thylarch.
This is premature thylarch, and we have to consider it as an abnormality, you see? And okay, this is an example of another example of premature thylarch, okay? In a 2-year-old female presented with prominent breast, okay? So this is 4-year-old girl. 4 year. And this is, it will be?
Again, premature.
And 4 also.
Yes, this is a premature thylarch, okay? So what is the premature thylarch? We described earlier the thylarch. The premature thylarch having the same effects of hormones, the same hormonal effect, but the difference between thylarch and premature thylarch, these hormones are abnormal. This is a normal process, but this is an abnormal process, though the same hormones and having the same effects, but their secretions and their presence, okay, is abnormal, resulting or an abnormal time or abnormal age, so result in growth of the breast in abnormal or unexpected age. So what is the premature thylarch? There are 4 pubertal variants of normal development: premature adrenarche, premature thylarch, isolated premature menarche, and non-progressive or intermittently progressive precocious puberty. So the premature thylarch regarded as isolated breast maturation in tenor stage 2 or 3 before the age of 7 or 8. and typically within the first 2 or 3 years of female, as we mentioned earlier. It is not potentially pathological. It is a benign process. Usually it progresses over time, then it regresses if it is not pathological, if it is not related to precocious puberty, okay? It is a self-limiting. There is no sign of sexual maturations. The classic type commences in the first year, okay? And the second, the age of onset, usually after 2 years of age, and it persists more. And it is associated with a higher incidence of uterine bleeding, okay? And ovarian system like that. The early development is triggered by disease such as tumor or minor trauma of the brain. It can be unilateral or can be bilateral asymmetric. Rarely bilateral symmetric. As we mentioned, if it is isolated, this is a benign premature cell arc, but it can be associated with precocious puberty if there are secondary sexual characteristics. Before the age of 9 in boys, before the age of 18 girls, and signs of secondary characteristic presence like pubic hair, vaginal mucosal thickening, acceleration of bone growth. Then if these are present, we have to consider the precocious puberty and seek endocrine evaluations, okay? Otherwise, if there is no secondary signs or there is no any suspicious feature of precocious puberty or any underlying causes, just an isolated premature cell arc, we have to reassure the parents, okay, after examining the child thoroughly and make sure there is no associated pathology, just Tanner stage 2 or 3, then and recommend follow-up. What is going on here? This is 1-year-old girl presented with bilateral increasing breast masses, which is what is the clinical significant? 1-year-old girl. Sorry, not 1 year, 1 month. 1 month, sorry for that. Let me change it. One month. Okay, 1 month old girl presented with bilateral increasing breast masses. What is going on? Neonate. Okay. 5-week-old male infant presented with palpable left breast lump. 2-year-old girl with palpable right breast lump. Okay, similar cases. What is going on? Nobody, no comment? Did you hear about neonatal gynecomastia? This is neonatal gynecomastia with ductectasia. These are dilated ducts. This is a breast bud, okay? And these are dilated ducts. This is, again, here, this is a neonatal gynecomastia. This is not a neonatal gynecomastia, okay? This is ductectasia in a premature cell. But this is a neonatal gynecomastia. Look for the age. Okay, this is a neonate presenting with this swelling and erythema. And look here, there is increased vascularity and there is surrounding edema. What is going on? There is inflammation and mastitis. This is a neonatal mastitis. Neonatal gynecomastia complicated with mastitis, another case seen here. So what is a neonatal mastitis or neonatal not neonatal mastitis, neonatal gynecomastia? The neonatal gynecomastia, the same as the premature celiac, but the different of a different age. The neonatal gynecomastia is benign proliferation of glandular tissue in the breast or in the breast tissue in an infant due to influx of maternal hormones, the estrogen, through the placenta while delivery, or due to neonatal prolactin elevation secondary to dropping estrogen level in maternal circulations, okay? It will result in the same process as we mentioned, proliferation of the breast tissue, giving Tanner 2 or Tanner 3 or whatever, result in unilateral or bilateral breast enlargement, okay? The neonatal breast enlargement is the same as premature celiac or celiac. It can be unilateral, bilateral, asymmetric. It is asymptomatic and it is physiological. It is a physiological process. It can be seen in up to 90% of neonate, okay? Can be seen both in girls or boys, because as we mentioned earlier, at birth, the rudimentary breast is equal in girls and boys. So both can be stimulated by hormones and result in proliferations. It is usually present in the first week of life and resolve spontaneously within few weeks up to 6 months, but sometimes can extend a little bit longer. So if the history of breast enlargement before 6 months of age, then it will be neonatal gynecomastia. But if it started after that and progressing, then it will be premature celiac. It may be associated with secretions of whitish milk, colostrum, okay? And it will disappear by itself spontaneously without any treatment. And sometimes the secretions, the nipple secretions, can be bloody in case of mammary ductectasia. See? And that, excuse me, can I show you this one? This is my patients, not my patients, sent to me from a colleague for opinion, okay? A neonate having bloody nipple discharge due to this bilateral ductectasia, proliferation of ducts and ductectasia in a 1-month-old girl. Okay, so since it is a physiological process and just the management, it will be reassurance of the patients and follow-up. Okay, what is the clinical significance in the case of premature cellular, neonatal gynecomastia, and these things? Early cellular, premature cellular, neonatal gynecomastia. The clinical significance, we are afraid from erroneous interpretation of breast enlargement in either condition as pathological. That can lead to surgical excision, rendering the child emastic, or biopsy that might damage the breast bud and result in asymmetric hypoplasia. Radiologists need to have prior knowledge of normal breast and its variant to be able to detect abnormality. Other causes of hypoplasia and emastia are trauma, radiations, and so forth. Okay. This is my patient, 9-month neonate with increasing right breast tender lump. What do you think? 9 months. Is it premature cellular or neonatal gynecomastia?
Premature. Premature. Fine.
Sarah?
أيوة.
Excellent. You're right. After 6 months, progressing, started later after 6 months and progressing, then it will be premature cellular. This case, 3-day-old boy with lump in anterior chest bilaterally.
Neonatal.
Neonatal what? Yes. Only neonatal gynecomastia? Or associated with?
Dilated ducts.
Associated with ductectasia. Yes, this is neonatal gynecomastia with ductectasia. Okay. Which ternary stage is this?
Tenor 2. Tenor 2.
It is 1. This is tenor 1. This is the nipple.
Okay.
That is the nipple. This is the area, okay? This is the area. This is ill-defined tissue. Okay. Which tenor is this? Stage is this?
Tenor 3.
3. Another suggestion? Another suggestion? Other suggestion? No one? Are you sleeping? What is the clinical? Suhair?
Yes.
What is the clinical?
13-year-old boy.
You got it?
Yes, boy with tender stage.
I made it. I highlight for you the gender. So still you did not recognize. So this is
Physiological gynecomastia.
gynecomastia. It is physiological gynecomastia. Okay. Which ternary stage? 13-year-old healthy girl. Ternary stage.
This hypoechoic area, I think this is ternary stage 1.
When?
No, this is 5, ternary stage 5.
It is not a diffuse. You have hyperechogenicity here, and you have central line hypoechogenicity. So
Ternary stage 2.
this is stage 3. Stage 3. And this one. Look here. It's more or less the same. Look, central hyper, hypo, peripheral hyper. But look for this one. This is the nipple. This is the areola. And look for the extension. If you don't know the size, look just for the extension from the nipple areolar complex. If it is just confined to the nipple areolar complex and usually not extend to the back of the breast, this is 2. If it extend even here like this, but still extend slightly more than the nipple areolar complex, it will be 3. And what about this? You have central. So if you have central hypoechogenicity and peripheral hyper from 2 to 4. So here you have central hypo and peripheral hyper. But what about the extent? The nipple areolar complex here and the extent more larger. So what do you expect? It will be stage
4.
Stage 4. It will be stage 4. What about this one? It will be, look, this is the nipple areolar complex, and that is the extent. Central hypo and peripheral hyper. But look for the extent from the nipple areolar complex.
3.
Yes. Now you got it. This is 3. What is the background parenchymal here? The breast composition. This 16-year-old lady or girl having a fibroadenoma. What is the background?
Homogeneous background, ecotexture, fibroglandular.
Excellent. This is fibroglandular. Look here. This is the anterior mammary fascia. And look for the parenchyma surrounding this. It is iso to the fat. So this is glandular. That it is homogeneous fibroglandular. Okay. This 13-year-old girl. No, sorry, not 13, 3-year-old girl. So we are dealing with
Premature cellular.
excellent premature cellular. Is it expected to be like that?
You have to check the hormones of the patient.
Yeah, but yeah, the asymmetry expected to be asymmetric. But yes, we have to check to have endocrine. This is the premature cellular. It has to be regressed. But the patient and this one. It's also asymmetric. What is your diagnosis? The previous one, premature cellular, and this one?
Gynecomastia also.
Excellent. Now you notice the highlight.
Yes.
Okay, this is gynecomastia, unilateral gynecomastia. This is 6.5-year-old girl presented with an increasing left breast lump.
Premature cellular.
Excellent. This is premature cellular. This is premature cellular. Okay. So to summarize, what we have said, breast development and evolution mediated by hormones, estrogen, progesterone, prolactin, growth hormone, and others. Breast tissue is dynamic and responsive to hormonal changes, which also need to be understood about imaging patients before menarche, during pregnancy, lactations, and after menopause, and with hormonal replacement therapy. To not cause any harm to patients and mistake normal anatomy for pathological abnormality. It is necessary to have prior knowledge of breast anatomy and physiological changes to avoid problem in distinguishing between normal and pathological changes in the breast based on age by ultrasound procedures. Because the young patients ordinarily do not undergo mammography, ultrasound is the best technique in this age group. Radiologists should be aware of ultrasound appearances of the primitive ducts and avoid misinterpreting the hypoechoic retroareolar bud, breast bud, in the case of premature thelarche in prepubertal child, or the thelarche in pubertal stage, the retroareolar glandular tissue enlargement, and in case of neonatal gynecomastia as abnormality requiring biopsy. Biopsy of hypoechoic retroareolar breast bud can lead to hypoplasia, and if it is removed surgically, the breast will not develop and the child resulting in emastia. The child become emastic. The ultrasonographic comparison of ternary stages is widely used to grade normal breast development into 5 stages in pubertal girls. So all of the above mentioned findings reveal that ultrasound is a good, very thorough image modality in breast imaging. Thank you very much, and I hope it was beneficial. And if you have any question, you can ask. The other physiological changes, ultrasound appearance and physiological changes during pregnancy, menstrual cycles, menopause, we'll discuss in the upcoming lectures, inshallah. Any questions?
No, thank you. Thank you,
Okay.
Dr. Abab,
You are
for this
welcome.
lecture.
You are welcome. I hope it, I did not take you so long.
It's very, very nice and good time. Finish in a good time of 2 hours. Great.
I couldn't recognize what you have said. Can you say it again?
I think it was a good lecture and we finished it in 2 hours.
Thank you. 2 hours now?
Yes.
Oh, because it was interactive.
Yes, yes. Very, very nice.
Yeah, interaction usually prolong the